today. It's a real pleasure to be here and see a bunch of people I haven't seen for a while in some cases. I want you to note my conflict of interest. I'm also an owner, one of the owners of the Health Utilities Index. So it says a brief history. If you're ready for a nap, this is a good time. I couldn't stop myself, the self-control, and I've got too many slides. But there's a lot to cover, so we're going to work through it and see what we get. So we're going to start out with an introduction on assessment of health-related quality of life. Some really boring stuff with equations on multi-attribute utility theory and functional forms, one of my obsessions. And then look at some generic multi-attribute preference-based measures, particularly obviously the HUI family, but some others. And then look at applications in clinical studies, health technology, actually population health, and then health technology assessment, and provide a few conclusions. All right, so I'm going to start with a definition that I use, done by a medical sociologist, Donald Patrick, that fits well with my paradigm. So what is health-related quality of life? It's the value assigned to the duration of life as modified by impairment, functional states, perceptions, social opportunities that are influenced by disease, injury, and treatment policy. I'm told opera singers learn to say that with one breath as a voice exercise. So you have all this stuff about health status and what influences it, and then it's the value attached to it. So in the health status classification systems for HUI, we have a way of describing your health status. That's the health status part. And then when we apply the scoring function, it becomes health-related quality of life. We've got the value of it on a particular scale and using a particular approach. So we've got a taxonomy of health-related quality of life measures with the criteria here. There are lots of useful criteria, but this is by the nature of the population for which the measure is suitable. So you've got a bunch of specific ones. So pediatric asthma quality of life questionnaire, frail elderly, brief pain inventory, etc. And these measures are tremendously useful and provide are often very responsive and focus on a particular disease or condition and the effects of its treatment, but don't allow for comparisons outside that disease. Right? So then we go to the generics, in which we're going to spend a lot of time on, so to speak. We've got health profiles. So your health, multiple dimensions, or in economics decision management science parlance, multiple attributes. And some aggregate into a single score, like the sickness impact profile, and some do not, like this short form 36. All right, so now still within the family of the generics, we could assign this value by having you evaluate either hypothetical health state descriptions or your own current health using one of these techniques. We could use willingness to pay, or, and this is what we're going to talk about today, sometimes called the indirect approach. We could devise a health status questionnaire to describe your health status and then value it using a preference-based measure. And so the grandparent of them all, the quality of well-being scale, Jim Bush, we'll talk a little bit more about that soon, and then a variety of the prominent ones that have evolved since then. All right, so why use this approach? Well, there are advantages and disadvantages to everything. One advantage, the disadvantage of the direct to Standard Gamble, VAS Standard Gamble, is it's cognitively demanding, time-consuming, takes really good interviewers, and so there's less burden on both respondents and study staff with the generic multi-attribute measures than with this direct. You get a curious kind of beast. You get self-assessed health status. The patient fills out the questionnaire, but then it's valued using community preferences. All right, the scoring functions based on preferences gotten from a random sample of the population. That fits the guidelines for CADIS, NICE, etc. quite nicely, but it is a kind of curious construct. And you can get evidence on health status, health-related quality of life. It's got integral sale properties, parametric statistics, all that good stuff. And in particular, you can use it to aggregate quantity and quality of life. And two of the summary measures there are the quality-adjusted life years and health-adjusted life expectancy. And I'll show you examples of both today. All right, so now the exciting part. I mean, now the boring part of it. So there are three major families of functional forms used to estimate multi-attribute utility functions. The simplest one, the linear additive, easiest to use, makes the most restrictive assumptions. It says there are no interactions in your preferences across attributes, dimensions of health status. This is the paradigm used for QW quality of well-being, EQ5D, and the short form 6D. There's the multiplicative form, which says, so it relaxes some of those constraints. It says there is potential for preference interactions across attributes, but there's only one kind of interaction, and this K term is the kind of omnibus interaction term. All right? Then there's the multilinear, which makes the least restrictive set of assumptions, and it says, well, this particular pair of attributes could be preference substitutes, this pair could be preference complements, and this pair there's no relationship. There's no interaction at all. All right? Obviously, this is much more of a chore to estimate than this. So the HUI 1, 2, and 3, and the AQUAL, the Australian or quality of life one, use the multiplicative form. And I'll show you a little bit of evidence on the multilinear later. All right. So in the beginning, there was the quality of well-being scale. This was the first, I think, generic preference-based measure. It had 4 attributes: mobility, physical, social. And then the symptom problem complex. Jim Bush was a primary care physician, so he kept adding. He wanted to describe his patients as important, prominent. Most of the scoring comes out of the problem-symptom complex. It was very widely used for a long time. Its use is tapering off now. I've used it in several studies. It worked very well, frankly. A linear additive scoring function based on visual analog scale scores. Now, I was not actually part of the HUI-1 project, so HUI-1 project, you'll note that the structure of this looks extremely like the quality well-being scale, and that is not coincidence. My colleague George Torrance thought the QWB had a lot of interesting and useful components, but the scoring function was very different, based on time trade-off, so a choice-based technique, and a multiplicative multi-attribute utility function. And as you'll see, it allows for, or the survey dictated, in a sense, there are states considered to be worse than dead. We'll come back to that. All right, so some of the things that were learned, so that, this is all an iterative learning process. Every study you've ever done, you would have done differently if you'd known what you were going to discover when you were working on it. QWB had big influence on HUI-1, and a theme that we'll come back to today. HUI-1 was devised to evaluate outcomes, long-term outcomes of survival for extremely low birth weight. And so you had multiple sequelae and different levels of severity. And so these multi-attribute systems confront that very nicely, thank you very much. The results from the estimation of the scoring function said there's no way in hell this thing is a linear additive function. The multiplicative was supported. All right, and that's a theme you'll hear again and again. And very interestingly, this was I think one of the first studies that discovered states worse than dead. 89 of 112 respondents identified at least one of the states as worse than dead. Now, fortunately, George Torrance, in his obsessive compulsive way, had anticipated this in the instructions for the interviewer. What do you do if they say this is worse than dead? Well, you put this and then you proceed. But they, I think, were surprised at the prevalence of states worse than dead. And that had influence on what we did before. And then George went back to von Neumann, Morgenstern, expected utility theory and said, well, if we're going to have states worse than dead, we need to transform them in a particular way that is consistent with the underlying theory, positive linear transformation. And so arbitrarily, the theory doesn't say this. The literature has said, well, if there's 0 to 1 for health, we're only going to go to 0 to -1 for worse than dead. All right, so it's a pretty arbitrary choice, and that limits it. And then within that space, you have a defendable transformation. All right. The next step in getting to the HUI-2 and 3 was David Cadman's study of child health. And among the biggest contributions here was David said, well, Jim Bush sat down and said, well, these are the attributes, and other researchers sat down and said, these are the dimensions or attributes that are important. Well, why don't we ask people what they think is important? What a novel idea. And so went out to a small sample of the population and said, what are the most, with a list of 15 attributes gleaned from all the existing instruments at the time, and said which ones of these are the most important. And this is the top 6. Well, it's actually the top 8. There's some sleight of hand, I don't mean that pejoratively. Sensory is vision, hearing, and speech. So there's really 8 there, not 6. But these were the ones that were most important. And all right, now, back in the mid-'80s, we got a grant proposal from the Ministry of Health to do a cost-effectiveness study for treatment for 3 major childhood cancers. And what was in the grant proposal was we would write up approximately 13 holistic health state descriptions describing the prevalent outcomes. Disease-free survival with no problems, disease-free survival with cognitive impairment from CNS prophylaxis, disease-free survival with mobility restrictions, et cetera, et cetera. All right, so then we thought, well, we better check out if these make sense or not. And limited budget, blah, blah. And I fortuitously said, well, who knows? My colleague, pediatric oncology colleague, Dr. Ronald Barr, says, well, who knows a lot about how the kid's health is? And we didn't want to bother the parents. Nurses. So we went to the nurses and said, I want you to think about the kids who are off of active treatment. So in a sense, survivors. And I want you to classify them into, say, which can you put the kid in one of those 13 health states? And the nurses said, boy, this is interesting. This is really important. Thank you so much. And then they said, then the shoe dropped. Yeah, the health states are really useful, but you've omitted various combinations of sequelae. Right? So the kid has both cognitive impairment and emotional problems. Or you got both the sequelae, but you didn't get the level of severity right. All right? So it said, okay, that makes sense. All right? So we gave him 27 health states the next round, and we got exactly the same answer. Right? Really good, really smart. This is really neat, but multiple sequelae, varying levels of severity. You're not getting it. I've got too many round hole square pegs. And we all kind of looked at our shoes at the meeting and sort of said, now I'm not sure which of us said it. Expletive deleted. We're going to have to do a multi-attribute system. Right? The only way to be able to handle in a compact way the multiple sequelae, different attributes affected, and varying levels of severity was to forget the direct utility assessment of hypothetical health states and to go to a multi-attribute system. And Bill Furlong, who worked on the project, had worked on the David Cadman's project. So Cadman's work about what were the most important attributes fed directly into what we did. So we have vision, hearing, speech, mobility, and we added fertility because subfertility and infertility are sequelae of some childhood cancers and their treatment. So that had to be added on. I'll tell you some more about the estimation of the function for that. All right. Now, because we took Cadman's work and said these are the most important attributes, and we didn't think through the structure of those attributes as well as we'd like to, we ended up with a lack of full structural independence. And the really great example for that is level 5 mobility is you're unable to control or use your arms and legs, and that precludes being in level 1 self-care. All right. So we had then to do this tap dancing of asking backed-off corners to get at the preferences and generate a lot of work, etc. So I'll skip the rest of that. Now the other thing we did in our obsessive compulsive, I guess I don't think there was anyone on that project who wasn't obsessive compulsive, is we had each respondent give us enough information to estimate an individual level multiplicative multi-attribute utility function for that person. And then we also did our beautiful, wonderful, well-behaved respondent called person needs. And so we took a whole bunch of HUI2 health states, with the full range of no problem, few problems, down to severe. And we scored them each 194 times and took the mean. And then we took the same states to the person mean function and plowed it through, and they're all the same. All right. So that had an important implication for how we did things in HUI3, which was more complicated, that we said we don't have to do this at the individual level, we can just do it at person mean level and cut to the chase. And so we could have different people do different parts of the puzzle for us. Okay. All right, so now we've got HUI2, we got a scoring function for it, we're chugging along, and with about, I think 3 months of warning, Statistics Canada says, well, we'd like you to modify that system for use in the 1990 Ontario Health Survey. So that's where the HUI3 came from. That was its first. And given that experience with the HUI2 lack of structural independence, we kind of really dug in and said, okay, we're gonna get out the hammers and sledges, and we're gonna get this thing structurally independent so that it will make things a lot easier. That really facilitated the preference elicitation interviews, no backed off corners. It also makes the questionnaire quite efficient. I'll show you in a minute, I'll show you some evidence of that nature. So in going from HUI2 to 3, many of the same concepts were retained. We split sensation into visual, hearing, and speech separately. So we had done some work with parents of kids who had brain tumors, who had problems in 2 of the 3, and so the parent system is filling out the HUI2 questionnaire. Well, how am I supposed to answer this? And on the basis of the vision impairment or on the basis of the hearing impairment? And we said, well, give us the worst one. But so clearly lumping those together was not the best thing to have done. Self-care was in HUI2 because people told us it's important, and it is. And then we figured, well, what do we not have already in the system that tells you why people would be limited in their self-care? So we got vision, so being blind might be a problem. I still have problems with vision anyway. Et cetera, et cetera. And we thought it through, and what we didn't have was small motor. And so we took that self-care out, and we put in dexterity. All right, so this is sort of indirectly about the structural independence issue. This is data out of a pretest for cycle 3 of the National Population Health Survey, and they tossed EQ5D in. And notice the rather high degree of correlation among many of the attributes within EQ5D, right? So in a sense, that's a lack of structural independence. There's an overlap here. It also makes it an inefficient questionnaire because a lot of the information that you're getting on usual activities is already in the information you got on mobility, et cetera. Now this is the same thing for HUI2. So you'll note that the majority of these correlations are negligible. Only a few are in the kind of medium range, right? So this is kind of indirect evidence of that we actually did get structural independence across the attributes in HUI3. We have if we have time later, some really interesting anecdotes about how we qualitatively tested that. All right, now this is the within the skin. So HUI says it's within the skin. It's got your physical and mental health, but not your social interaction. Does your health allow you to engage in social interaction, or does it impair you from engaging in social interaction? And part of the motivation for that, ironically, was John Ware. So our research and literature identified several reasons for restricting the definition of personal health to its physical and mental components. In a model of health status at the individual level, physical and mental are similar in that they end with the skin. They do not directly involve other people. A model of health status that defines social factors as external explains empirical results better than one that includes social factors as an integral component of individual health. Such model acknowledges that social circumstances may directly affect health status. It does not, however, define health status in terms of social circumstances. And that's the paradigm that we used in HUI. And so it's compatible with Martha Sen's capabilities approach. Does your health status allow you to do stuff you want to do, or does it impede you from doing stuff you want to do? All right, so HUI 3, 5 or 6 levels, 8 attributes. Y8, well, there's the magic number of 7 plus or minus 2. So we should have gone to 9, right? And in some other work, I'm thinking of going well past 9, but not with HUI. So this keeps the vector kind of within the cognitive capabilities of most respondents. Murray can juggle a 17-element vector, but most of us can't. And so again, a lot of action worse than dead. All right, and I'll tell you some stuff about how we estimated this. So we had 2 surveys. We had the voting rolls in Hamilton, and we randomly allocated people to the modeling survey or the direct survey. The modeling survey, obviously, was used to estimate the multiplicative multi-attribute utility function and 2 multilinears. Right, they're real gluttons for punishment. Let's look at the multiplicative decomposed approach. So the other folks were randomized to the direct survey. We gave them 70. Each person got, I forget how many, a dozen or so. We randomly allocated blocks of states. So we had standard gamble scores out of sample for 73 HUI health states. And then we had the scores from the person mean decomposed multiplicative function for the same 73, and we looked at agreement. And the agreement's 0.88. It's a very high level of agreement between predicted and observed. Right? So there's evidence for the multiplicative function of predictive validity. We used a 2 to the 8th fractional factorial design for the multilinear. That by design, we could estimate all main effects. 26 of 28 two-way interactions, and 4 of 56 three-way interactions. All right. So we spent a lot of time deciding which two-way interactions we were going to throw overboard. Results. Now I can put too many results up on the board here. So let me just talk through the first version. The restricted multilinear, restricted to go through 0, the all worst HUI state is 0, and 1, the vector of 1, the 8 ones in perfect health. So all main effects were negative, quantitatively important, statistically significant. 26 of 26 interaction terms are all positive, indicating preference complementarity, where quantitatively important, statistically significant. Actually 3 of the 4 three-ways were as well. Somewhat similar results when you didn't restrict it to go through. But the real message here, I'll come back to one of the other messages, but the big message here was when we took both of the multilinear functions and tried to predict the scores for the 73 health states, the agreement between predicted and observed was much lower than it was for the multiplicative function. And the fact that we had this overwhelming evidence of preference complementarity tells you why the multiplicative function works well. And the coefficient on that indicates preference complementarity. And so this kind of omnibus term kind of mopped it up nicely very much. The prediction of at least 3 of us on the project had been the multilinear would outperform the multiplicative. And I was wrong. I wasn't alone, but I was wrong. All right, so that's what the scoring tableau looks like. If your only problem you have is that you need corrective lenses to see well, then we take the 0.98 and we multiply it by the 1s. And we multiply that by 1.371, and we subtract off 0.371, and we get 0.97. Okay, so it's very easy to program, very easy to compute the score for any old state. All right, so if you want to use this thing, some guidance, and we can talk more about this later if you want. Clearly should have been up there. A clearly clinically important difference in an overall HUI score, difference or change of 0.03 or more is clearly clinically important. For a single attribute score, 0.05 or more. And if somebody asks questions later, I can tell you where the hell we got that from. Now I want to shift to some evidence on a couple of applications in clinical and otherwise. So this is cross-sectional study done at Harvard on type 2 diabetes. And this is kind of just simple known groups epidemiology sort of approach. So we got a bunch of folks with type 2 diabetes. There's skewness in this distribution. Commonly there is. So they use medians. So the whole cohort, the median, sorry, is 0.7. Those who happen to be depressed is much lower. All right, you'd expect that. Right? Number of medications. There's a lot. So I think there's some pharmacists in the room. One would expect if you have more prescription medications that your health status would be lower. It is. Being on insulin versus not being on insulin, again, you get the difference you'd expect. Not interesting here, it's only when you've been on treatment for 11 or more years that you're decidedly less healthy, and that may not be the treatment, that may be just age, right? All right, so kind of basically looks reasonably well. Good. So this is a study where we looked at longitudinal construct validity or responsiveness. So this was a natural history cohort of how bad it is to wait to have your hip replaced. And we used every measure known in person kind. So a bunch of disease-specific measures, Harris hip, MAC-TAR, and the WOMAC. And this is post-surgery minus pre, and they get a lot better at the cohort level. We also did the standard gamble on how you've been the last 2 weeks, think about it, and then you do the standard gamble with dead and perfect health and your current health state. And you go from 5.9 to 7.6, again, very substantial gain. HUI2 overall, very similar gain, interestingly enough. Self-care, you'd think that probably if you got your hip replaced and you had less pain, your self-care would go up, and it does go up modestly and importantly. And I didn't show all the HUI2 attributes, obviously. HUI3 overall, even a bigger estimate of gain. Vision, nothing happens. Well, you wouldn't expect elective total hypoplasty to improve your vision. I guess the anesthetic might have damaged your vision or something, but you wouldn't expect that. You would expect their ambulation to go up a lot. It did. You expect pain to go down a lot. It did. We also used version 1 SF36. And if you then do the physical component summary and the mental component summary, there's a lot more action in the physical than the mental, and that's appropriate. If you then translate that into SF6D, you get a gain of 0.1 according to SF6D, as opposed to 0.17 according to standard gamble, 0.18 according to HUI2, and 0.25 according to HUI3. Paul, is SF6D a utility? It is a preference-based scoring system for SF36 or SF12, or the veterans 12. Yeah, so it was estimated after the fact and off of a subset of the SF36 space. So why SF? Why less? Why so little less gain register? Floor effects. SF is well known to have substantial floor effects. So the people were here. SF stopped here, and after surgery they were up here, and they're only capturing this part of the gain, not the whole gain. But otherwise, I mean, SF was really great in the sample, and as it is in many samples. What happened? Well, function went up, while the pain went down, the physical function went up. All the right things happened, but the floor effects attenuated its usefulness. All right, so this is a population health application. 2002, 2003, the Robert Wood Johnson Foundation paid Statistics Canada and the Center for Health Statistics in the U.S. to do the same survey in French, Spanish, and English with StatCan interviewers at the same time. Right? So rather comparable data. And HUI3 was in there. And so we used that to calculate, to take the life expectancy and say, well, you live that one more year, and what is the average utility score associated with that year, and you multiply it through. So it's an expansion on standard life expectancy. So an 19-year-old at that time in Canada could expect to live longer than in the U.S. And then if you adjust it for morbidity, a 19-year-old in Canada could expect to live have 2.7 more years of quality than someone in the U.S. About 2/3 of that difference is due to difference in mortality, and 1/3 the difference in morbidity. Right? So we live longer and better, and spend about half per capita on healthcare as in the United States. But there's no chauvinism involved. All right. So this is kind of an old health technology assessment application. Thingvis, which was an injection into your knee as loop job on your knee. People randomized. And the study was designed to speak to clinicians and to speak to third-party payers. So the WOMAC for the disease-specific generic profile SF36, and then HUI 2 and 3, but we're just going to look at 3. The HRQL and the cost borne by patients and the HRQL was all done by telephone interviews because they didn't want to generate study-related visits on the costing. They wanted the cost of the intervention to just be the real clinical cost, not we brought you in because we wanted to have you fill out a questionnaire. All right, so the arms were appropriate care with the injection or appropriate care. Appropriate care was defined by the guidelines from the American College of Rheumatology, and you'll note that just going from standard care to appropriate care generated a reduction in pain on the WOMAC scale. All right, so just getting everybody up to what they quote-unquote the guidelines were supposed to be doing. And then you'll note that that plateaued off for appropriate care, and there was a bigger reduction in pain in the intervention group that was sustained. Part of the design of the study was Charlie Goldsmith has forced the clinicians to say, by how much would pain have to be reduced for you to say the patient was improved? So they said if baseline pain fell by 20% or more, that patient would be deemed improved if they had that low pain at the 12-month follow-up. All right, so you can see that in the treatment group, there's a higher percentage of change reduction in pain, but there's a substantial one in the control group, and there's a difference. All right, and then so you have a 28.5% difference. The intervention cost a net increase of $710. So it was $2,500 per patient improved. All right, so kind of a cost effectiveness analysis kind of thing that might speak to the clinical community. All right, but third-party payer might be interested in the cost utility analysis. And here you have the archetype, the area between the curve. So the change from baseline HUI 3 score, the control group did get better and then deteriorated some. The intervention group got a lot better and plateaued. And so over the year was a difference of 0.071 qualities relative to $710, $10,000 per quality. Okay. So that's a HTA type application. All right, so I am finishing up, so there will be some time for questions. So I think I've provided you a glimmer or some evidence that there is cross-sectional construct validity evidence and longitudinal responsiveness, predictive validity of the scoring system. What I didn't show you is that HUI-3 in population health surveys also has predictive validity for kind of some important outcomes like dying. So if you look in the National Population Health Survey 1994-95, somebody's baseline HUI-3 score, controlling for a number of chronic conditions that income, education, sense of coherence, stress, social interaction, the whole, just about anything. HUI-3 predicts mortality quite nicely. Self-rated health predicts mortality quite nicely. And if you put them together, you get a better prediction. So each has some information the other one doesn't. That's not surprising. So there's substantial evidence about the multiplicative multi-attribute utility functions working well, particularly this idea of the preference complementarity. So from my not unbiased point of view, this calls into question generic preference-based measures that use the linear additive functional form, because we have rather compelling evidence, not just for HUI, that if you allow for a multiplicative form that takes on interactions, there are interactions. Okay, yeah, I did say that already, didn't I? Okay, and I think this is the last one. Population health outcomes. HUI may have some modest ceiling effects. So if you use TWB or SF60, very few people, even in a population health survey, are in perfect health. And if you use HUI, there's a few people. There's a non-trivial group in perfect health. If you use EP5D, 40 to 80% of your population is in perfect health. So not very useful at all. But there are some ceiling effect issues here. Doesn't seem to have any floor effect problems like the SF did in the elective total hip arthroplasty. HUI 2 and 3 are applicable in terms of how they describe health for children 5 and up. Okay, I mean, 5-year-olds can't fill it out, but a nurse or a parent can. By 8, they can do it pretty well by themselves, frankly, or with a little help. We have a couple preschool, but we have one published, an earlier one, preschool version that took the same concepts out of HUI 2 and 3 and said if you were 3 years old, how would you describe mobility? How would you describe vision? How would you describe hearing? And that's had some modest use and some uptick of use lately. Applicable across a wide range of clinical conditions and health problems. Generic instrument seems to be applicable lots of places, but it will miss stuff that specific instruments don't miss. And there's some particular applications where, because it's got vision, hearing, and speech, it turns out to be particularly useful. Macular degeneration, cataract surgery, cochlear implants, stroke or stuttering, and on the speech side, that the other instruments usually just don't seem to pick much of anything up, and yet it's important. So that's, gee, I managed to get through that in 45 minutes. Okay. I guess I'm open to questions. Am I open to questions?
Yes, you are open.
I'm not sure if I saw that right, but I think in the original version of the HUI2, use time trade-off, and then in the 3 use standard gamma.
No, actually, HUI1 used time trade-off.
Okay.
And 2 and 3 were based on standard gamma. And why?
What's the evidence for that? Yeah.
I'm to blame for some of that. So I wasn't on HUI1, and so I'm working with George Torrance on, and we're working on HUI2. And I said, well, why bother with the TTO when we could use a standard gamma? And partly that was more feasible because there had been some improvements in how you conduct the interview, for which Bill Furlong was largely responsible, our colleague. And so we went to standard gamma because you're making the von Neumann Morgenstern assumptions and no additional assumptions, where if you go to TTO, you're making additional. So why borrow assumptions when you don't have to do them? And it worked. We had very little difficulty. But it is sort of in a sense curious that HUI1 is based on TTO and 2 and 3 are based on standard gamma. The usual thing that we say in the field is you VAS to get initial ideas and give people familiarity with the health states, and then you go to choice-based. And in that sense, TTO is quite fine. It's quite more than acceptable. But I prefer the standard gamma unless you've got some particular context where it's not going to work and the TTO would. Usually it goes the other way, though. If you go to women with breast cancer and you frame it as time trade-off, they're often, survival is so important. But they'll do a standard gamma, even though survival is there, but it's just not quite as, So you can sometimes get them to trade, you can get them to get some action there with the standard gamma where you can't get with the TTO, right? You probably can't put one the other way. Murray? I don't know. No, go ahead.
So, you always describe in the HUI development how you've taken a within-the-skin approach to health. And, if you look up the WHO definition of health, they talk about the mental and social well-being.
Right.
And increasingly people are aware of the context of caregivers, and especially for childhood. I'm just wondering if your views about what health is have changed over the years. Whether you think now, with the wisdom of hindsight, there is a social dimension of health.
Yeah, and I think if I were redoing this, I would do basically the same thing we did. And I think there's some confusion, but I think there's also some fundamental issues. So I think there's some confusion, clearly. And if I go to the back to population health survey and I make HUI3 the dependent variable and I put social interaction on the right-hand side, I get the result you expect. So social interaction clearly is important and influential in health. And depending on your clinical context or the healthcare context or public health context you're in, dealing with the social part may be more important than the biomedical part. in impacting the person's health, but in terms of how you're going to define health, I mean, I think you can do it both ways, and each would have its advantages and disadvantages, but I'm still more comfortable with this, and it really is sort of SENS capabilities approach. My health status precludes my doing this, or allows me to do this, and social interaction, and it's a two-way street with social interaction. You engage in it. So when we did a we did some debriefing of respondents to the HUI3 scoring project. So partly we asked them, like, how did you do this, and how would you do that? And they gave us back our directions better than I could have given us back our directions. I was really quite impressed. And then we said, well, did you focus on particular attributes, or did you just sort of look at the whole health state? And some people said I looked at the whole health state, and some said I looked at particular attributes. Well, then which ones did you look at? And they all got mentioned. Pain, not surprisingly, was the most frequently mentioned. I forget was the least, maybe dexterity or something. But among those who said they looked at particular ones, all had high prevalence. So, all right. Then we said, well, how did you come up with we didn't say it this way, of course, obviously, said it in English, but, how did you come up with your standard Gamble score? Well, I looked at that health state, and I said, if I had those problems, I would be socially isolated. And so I gave it a really low score. So it's in there in the scoring function in some sense. The consequences of being in those, and I'll come back to elaborate on that, the consequences are in the scoring function in some senses. And then we also got, which is not particularly what we asked them, we also got, if I had that vector, I'd be a burden on my family, so I gave it a really low score. So in some senses, their social relationships were in there. So it's kind of proximal versus distal, right? Proximally, social interactions is definitely not in the health status classification system, but the capability to engage in it is. And distally, it's actually showing up in the scoring function because that was part of how people decided that this is not a really great health state because you're socially isolated for one reason or another. Paul?
I mean, your mental health component is the emotion to me.
That's right.
So, I mean, in a sense, it is part of what baked into the HUI3, the social.
If social interaction affects your mental health, yes.
Yeah, if you're socially anxious, for instance, you'll be, it'll come through there, plus maybe through the utilities.
So it'll come through the emotion attribute and therefore into the utility score. Yeah, and we just did some work at Kaiser's Center for Health Research using a cohort of teams without depression, teams subthreshold depression, teams with depression, chosen through the electronic medical records that Kaiser Permanente worked with. And we did EQ5D, HUI2, HUI3, SF6, SF36, quality well-being, 3 disease specifics, something else. I mean, it was incredible that they got these teenagers on the phone to do all that. And if you then look by those kind of groups, no, not depressed, subthreshold, depressed, both for EQ5D, actually all the HUI SF as well, but particularly EQ5D and HUI, there's just huge differences in the mean HUI score by level of non or level of depression. And then if you unpack the depression, when you look at mild, moderate versus severe, big differences. So for a measure that has relatively little mental health content, it's showing up. We had another study at Kaiser where they used the electronic medical record to find folks who were anxious in something. And then they gave them the Hamilton anxiety scale. Used that for asymptomatic, mild, moderate, severe, and if you line up the HUI3 scores, you could drive a truck. So again, even though there's not a lot of mental health there, it is showing up somewhere.
Yeah, I wondered if you could elaborate a bit more on the preschool version, both in terms of the classification system and the underlying valuation.
Okay, excellent question. The classification system I can talk about much more than the valuation. Okay. So Bill Furlong and I, with Peter Rosenbaum and Sarosh Segal, who's been doing these long-term follow-up studies of survivors of seeing the Berkeley, and they used HUI on older kids that survived longer. Quite successfully, it worked pretty well. It was very useful. And so she said, well, why don't we figure out what this would look like for a 3-year-old? So we sat down in an interminable but productive committee meeting to sort of say, take the concepts out of HUI 2 and 3 and say what would be developmentally appropriate, normal, some impairment, more, severe impairment for a 3-year-old. And so, just, then this were ordinal levels, all right, and so that existed, it was used by Saroj, Peter, used by, blanking on the name of a neonatologist in Texas, another one in Australia, and emailed me, I can send you those PDFs. And it worked pretty well, but it had no scoring system. Okay. So in one study, violation of whatever here, there were ordinal levels, and so I just added up the levels. And it actually worked. I wouldn't recommend that, but it gave you some ability. So currently I'm on a grant from CIHR with Ronnie Barr as the PI. And we're going to try to do a first step towards developing a scoring system for the preschool.
But these are still parent proxy, right?
Oh, parent or clinician.
Okay.
Yeah.
Still have issues around the completeness of
Oh, absolutely. But I think the evidence to date would indicate that you get a lot more information by asking, even if it's not, if the information is not as good as if you were asking a 12-year-old or the parent of a 12-year-old, et cetera, et cetera. So we're working on, and then as we started to work on this, of course, we ended up having to revise the system a little, so we're working on that. And then we're going to map the piece, this revised preschool system. If this is your vector on the preschool, what would your vector in HY2 be? Which would your vector in HY3 be? We have scoring systems for those. I mean, obviously, it's better to have a scoring system for the PCS system itself. But yeah, yeah, you can't do real precision, but you'll get some, kind of ballpark kind of stuff out of it. Yeah. So that's one of the things we're working on. It's in neuro. It's in one of the clinics right now. Chris.
Always great to hear. This preschool.
Yeah.
About how far down in the age range from go? We use Feeny in the pediatric intensive care hall.
And you got away with it.
Yeah, we got away with it. But basically, below 3, it seems to the question will lose meaning.
Yeah.
So we should, our interpretation, so we got a real fall off in conditions, but our interpretation was that actually the concept of an independent subjective quality of life for the child, separate from parents, starts to kind of fall apart.
I think our experience with the preschool version is not quite that. It doesn't go right there, and that's partly because you were using HY2 that just didn't go down. That you managed to stretch it down to 3. So we wrote PS at preschool at 3. We have successfully used it down to 2. And then I think past 2. I got a real pediatrician guy. But I think I wouldn't be very confident it would go lower than 2. And I think you just can't tell that much about that at this level. I mean, you can do physiologic tests by them, but I don't think you can tell it's sort of like how well does the kid move and how well do they see, and they're not communicating well enough to tell you they can't see, et cetera. So, but we seem to be able to get the preschool system down to about age 2, and it seemed to be generating in class and used it with a long follow-up study of survivors of neonatal units in British Columbia. It seemed to go pretty well down to 2. I'm not sure anybody's tried to go past that, and I would be skeptical. But on the other hand, well, yeah, and also on the other hand, there's a bunch of stuff that there are studies where we've had A2I in there. I didn't think it was going to work very well, and it did. So, Walter.
Thanks very much. You started off talking about values, right?
Yeah.
Valuations here. Let me ask you. So, in the generic sense, usually the population values preferences are applied. 2 questions. One is, which population? So is the population of BC the same as Ontario population?
Yeah.
So even within a country, or Canada versus
Yeah.
Ireland?
Okay. Can we work on that one first?
Okay.
Because I'll forget that. I have a level 3 cognition, and I will forget your other question. George and I were both level 3 cognition. Fortunately, Bill Furlong was not, so the project got done. So, how generalizable are the preferences you get from the general public? There was a whole bunch of questions there. The HUI3 was done originally in Canada in Hamilton. It's been done in France, the Netherlands, and Spain. And if you look at the parameter space of the all worse to perfect health parameter space, because different places, different investigators handle worse than dead differently. So not the dead perfect health scale, but the all worse to perfect health scale. Parameter values are extraordinarily small. QWB was done originally in San Diego, was redone with arthritic patients in northeast US. It was done in Trinidad or Tobago, one of those places. Parameter values, that function are very similar. Sickness impact profile was done in Seattle and redone in London by Donald Patrick, very similar. You do ET5D, every time you do it, it's a different parameter value. So, so for some systems that they actually were kind of Western civilization, seem to generalize fairly well. We had one of the cirrhosis studies and another study. So we had the kids fill out the HUI 2 and 3, and we did the standard gamble on their current health state. The mean HUI 2 score and the mean standard gamble score were the same, basically the same. To the point that, we said to the research associate who did the analysis, are you sure you didn't mix up the fields? And you're not repeating the same thing twice. Now, if I looked at the standard, so, that wasn't true, but it was the HUI 3 were similar, but systematically a little low, which is kind of what you'd expect given the nature of the system. So again, that was at the person mean level, using community preferences gave you pretty much the same answer as asking the cohort itself. Now, at the individual level, we're fairly agreed. But that's answering a different question. So, I think they actually do. I don't think you get remarkably. What you ask and how you ask it matters a lot. Who you ask doesn't really matter much. Maybe there are some minority groups that certain, but generally doesn't matter. Now, you had a second.
Yeah, so I probably largely covered off by this one. To what extent do you expect values?
Yeah, I don't expect, there are folks who do, but I don't expect them to change much over time, at least the way these health states and in the other generic systems are defined. These are very, when the WHO went out to find out what should be in the WHO call, they expected to get all this cultural variation, and they found out they got pretty much the same list of attributes that everybody else always had. People want their emotional health, and they don't want to be in pain, and they want to be able to get around and do stuff. And so I think those are very fundamental values, and I don't think they're going to change over time, because I think they are so intrinsic. And it's not an audience of economists, so probably a weak analogy for you folks. But if I do a household expenditure survey, and I group foods in large groups, like fruits and cereals and parameters of those expenditure functions are very similar across countries. If I instead have mangoes versus Macintosh apples, you get big cultural influence. But at that kind, and these attributes are kind of really core stuff. So I don't think there's much drift in how people. Now, obviously, there are some technological innovations that mobility restrictions are not as bad as they were if I have my electric scooter, et cetera, et cetera. But
so with this, unfortunately, I have to conclude the round. We're a little bit over time. So I'd like to thank David. I know he's going to hang around for a little bit longer, so if you have questions, come out. But thanks very much, David. Thanks, everybody, for coming. That's